when we taught this class. We sort of timed our lunches and breaks depending on when we needed to shift off. So if, sort of gotten used to a lunchtime at a particular time, I apologize if that's not what we were following. Again, we weren't, had not done that in the past. So I know we explained it before, but I wanted to explain a little bit in terms of the chat problem for at least our computer. I'm not sure how it shows up on others, but the problem is that we can't see the full chat without covering up our slides. So sometimes when there's a lot of activity, it flashes on our screen so quickly that we miss a lot of questions. And so it's hard to see where somebody has asked a question and then, okay, Eddie says that it's planned 9 to 12, 1 to 4. So if that's the administration, then we'll do that. We'll do that for a PTS lecture if that's what the administration says. Anyways, so a lot of times we miss the full context of the chat, so we can't see it. So it's not that we don't want to answer your questions, but literally it just goes by so fast we don't see the full context of things that are going on. So we can either see our slides or we can see the chat. It's at least on our screen, you can't see both fully. So I apologize if I've missed some of your questions, and sometimes if I've moved on a different part of the lecture, Dr. Papp and I are happy to carry on the conversation with you offline, or you're welcome to carry on that conversation yourself. We just can't follow it all because we can't see it. So just sort of explain the chat part of it. So,
Doctor, I apologize to interrupt. Would you also kindly, for sake of some student who asked, explain what was that article assignment about?
Oh, the article assignment was pretty simple. So someone says reduce your slides, but then you see our computer, which we don't want you to see because there's a lot of personal information on it. So that doesn't work for ours. We tried various ways. We spent a long time yesterday trying to figure out how to not show our computer. So it didn't help for us. So the article, it was pretty simple. All I wanted you to do is choose one of the posted articles, read it if you want to, or don't read it if you don't want to, but it'd be nice if you read it and the abstract. You can just read the abstract, and then just tell us which one that you've read. This helps us to understand what is within, what sort of the specific interest within the class, so that we can add our slides or change our slides next time, and be able to talk in the PTS lecture about more things that are interesting to you. So that's all it was. Just pick one of the articles and tell us which one it was. So that's all, nothing else. I can't remember because I got a little distracted before we ended, whether the insomnia I had covered. Okay, thank you, Rebecca. So the insomnia, I think, did I cover or not? I can't remember. That's where I stopped. Okay. So again, the sleep issues are pretty primary within the side effects you're going to see, either medications that create sedation or create insomnia, or they're going to have primary insomnia or sedation. I have actually a patient who's just always sleepy. So the medications that are going to be more likely to cause insomnia are bupropion, especially the extended release. So really query your patients what time they're taking that medication. Sometimes even an extended release taken very early can disrupt sleep at night, but certainly if they're popping a pill like 3 p.m., it would very likely to, it's going to upset their sleep. And then you do all that other, reducing other sort of stimulants too. Especially caffeine. Caffeine's one of the screening questions I use for my own patients. And then really behavioral treatment is the primary treatment when you use. So CBTI is really the standard of practice. So if you can get them into some behavioral thing for working on the insomnia beyond your own medication prescribing. But you might reduce the dose. So it's a cost benefit about whether they're going to be able to improve sleep, and maintain that medication benefit that they were getting. Again, we talked about changing the timing of the dose. You can also add some medication or over-the-counter, be careful of diphenhydramine. So some of the prescriptions you might add at low, again, this is low dose, not at antidepressant effects, would be the antidepressants of trazodone, doxepin, mirtazapine, gabapentin, or 4. So mirtazapine, again, you've got to think low dose, 7.5. So if you have a patient coming in at 15 milligrams of mirtazapine, there's a possibility they're still getting a sleep effect from it, but a good possibility they're not. So frankly, it's something that a whole lot of prescribers don't know that you need to keep to a low dose. So you can add these other things. And I know you have sleep classes, a whole class about sleep. So I won't go on with that. You can pick up more in that one. So the weight gain issue, and this is one of the primary things that people complain about either reason they're not going to take the antidepressant or they're going to get off of it. And some of the gain is actually not associated with caloric intake. So there can be, weight gain, particularly some of these medications like mirtazapine and Paxil. So there can be a little bit increased appetite, but not necessarily. So the medications you're going to be looking out for are mirtazapine, paroxetine, and then the antipsychotics, particularly quetiapine, and hopefully not olanzapine, and then the TCAs except dazipamine. So what you can do, you can order those labs for serum glucose, look at lipids, and then check weight. At least we were taught doing the kind of checkup is that we're going to do the waist circumference pretty regularly. And then you can switch or augment. So you can switch to bupropion if it's really appropriate, but sometimes just augmenting with some bupropion is going to help with the weight gain. And then again, switching to another antidepressant, in particular paroxetine, I think it's a good idea to get patients off of paroxetine unless it's absolutely necessary because the weight gain associated with, and then all that other behavioral management stuff. And of course, again, the referral to primary care. So about a third of the patients are going to get weight gain. So that's quite a bit. Oh, and then I forgot to mention, so alternatively, if you have a patient that is underweight, a little bit of mirtazapine goes a long way for getting some appetite stimulation. So in those people, be careful in the elderly population, but I have seen it. If it's an eating disorder issue, we're talking a lot more complex sort of management. But if it's something that the patient, just because of their depression, they're just not eating, then mirtazapine is a great drug to add on to it. And think about too, and I didn't know this until recently, that weight gain is actually another cause, a large cause of malpractice claims. So if a patient puts on 25 pounds, 30 pounds from something like olanzapine, that can be a risk for you for malpractice as well, besides of the patient's health. So sexual dysfunction, and this is something, again, I hear a lot of complaints about in my practice. So there can be anorgasmia, genital anesthesia, decreased libido, and general erectile dysfunction. That's because of the serotonergic action, the SSRI and SNRI. Action is about 24 to 30%. With bupropion is much less. So much lower sexual side effects is bupropion and vortioxetine. Can't remember the brand of that. Trintellix, that's right, Trintellix. So those are ones you want to think about if sexual dysfunction is a part of the scenario. But you also want to, so someone is saying that they are having sexual dysfunction, you might want to query them about sexual function prior to treatment. So, I mean, is some of the sexual dysfunction actually part of the depression or, relationship issues, things like that? But so it's not always about the about the medication itself. So waiting 2 to 3 months, remember some of these medications are, at the beginning are going to have more side effects. So if you wait 2 to 3 months, it might go away in about a third of the patients. So typically patients won't volunteer. Occasionally they do, but it's something that, to be able to ask specifically about, particularly if they're thinking of getting off their medications, to be able to query, if this is one of the symptoms that they are experiencing. So you can switch medications to the bupropion and vortioxetine. You can also add some bupropion to the regime, which is going to help. And then there's PR and cyproheptadine, which isn't very commonly used, but it is it's an antiserotonergic medication that temporarily suspends the effect, and it's most often given to women. But you have to be pretty careful about using it if the patient is really, at high risk for continuing to not take their medication because they don't want the sexual side effects. So, and there's also the erectile dysfunction drugs. So even if it's more of a decreased libido or anorgasmia sort of effect of the drug, just having an ED drug on board will give more confidence to the patient, and they're more likely to not suffer so much from worries about their sexual dysfunction. And then, of course, timing the drug and reducing the drugs, but really only if it's, can be tolerated and is indicated. So it's always a cost benefit, any of these things. The cyproheptadine is given 4 hours before they want to have an orgasm for both men and women. It's also, by the way, that medication is also used for serotonin syndrome. So GI distress, nausea, gas, diarrhea, constipation. Remember, the GI effects are because of you have the serotonergic receptors in the gut. So a lot of these sorts of things will go away if you just wait. Sometimes changing of dose. Sometimes you just get them to take it with food, and they didn't even think about that. It'll take away some of the problems. And then if you gradually dosing rather than quick switch, quick increase, there'll be less GI effect. And divided dosing. So if it really gives them a stomach ache, try to see if you can get it more than one dose. And then you can add these various things that go along for helping constipation or distress, diarrhea over the counter. So if you don't feel comfortable prescribing these things, certainly you can send them to their primary care. So this is one of the areas where, depending on the level of their discomfort, it would be something that primary care sort of referral would make sense. You can also, for nausea, it's interesting, a little mirtazapine, just at very, very, very low dose, sometimes can help with the GI issues. So orthostatic hypotension, this is something you've learned about in other classes, and you have to be really careful in the elderly. And as I mentioned before, that trazodone, quetiapine, and MAOIs can affect the blood pressure. It's much rarer in the newer generation antidepressants, but it's clearly one that is a fall risk for patients you have to be careful about. You can switch again, or you can do divided doses for the patient, and then educate it, just that simple stuff about not getting up too quickly. And here I have it right here, refer to PCP for medication increase the blood pressure. So the blood pressure part of it is more complex than just our medication. So it's something to think about referring to primary care. So emotional flattening, this sort of decreased spontaneity, motivation, emotional liveliness. I mean, they look the same no matter whatever medication it is. So it's a late onset side effect. You're going to see this more like 6 to 8 months. That's where there's sort of a decrease. The serotonin has caused a decrease in the frontal lobes. So you could add a little bupropion or low-dose stimulants, again, something like an amphetamine or modafinil would be helpful. Here's a case where reducing the dose really makes sense because, you know, if you bring it down a little bit, maybe there's a little depression, but that's okay. You're going to have a little more emotional aliveness to them if you bring it down. You can switch to an SNRI, so you're going to get a little norepinephrine effect that way. Sertraline or Zoloft would be a medication to switch to. And this stopping medication is only if appropriate. So if you know that patient, every time they get off their medication, they become severely depressed and relapse is going to happen. It's a sort of a cost benefit that you're going to talk to the patient about whether or not this is something they really want to consider is going off the medication. So now we're going to talk about the red light side effects. You need to know these side effects in general. They're the ones that the medical community really want us to know for prescribing psychologists. So these are increased bleeding and easy bruising, low serum sodium, hyponatremia, QT interval long prolongation, suicidality, allergic reactions, serotonin syndrome, and drug interactions. And we're going to step through them. Before we step through them, are there any questions about the sort of non-serious side effects? Recommendations for treatment. I'm sorry, I don't understand what that means. What do you mean recommendations for treatment? Do you have some recommendations for dealing with which side effects? Oh, on each slide, I think you'll see at the bottom, it gives the action that you're going to take. So emotional flattening action, you can switch to an SNRI, you can stop medications, you can add bupropion. So at the bottom of each slide on each of these symptoms, you'll see the kind of action that you can take. And so it says what, okay, got it, all right. Okay, so now we need to talk about the potential for the low likelihood of side effects of each one. And if you have questions on it, we really need to stop and ask about them because you need to know, boy, this did not show up very well. Sorry, this is a increased bleeding look. You might have to go back on the internet. It didn't seem to.
No, I think it's pretty good.
You see it on yours, okay? So it looks just, I mean, it can look just like sort of modeling. It's sort of, you know, you see there's red and green, blue. There's some older bruises that are not. I had a patient come in recently. She had her every limb, this sort of thing. So if they're wearing long sleeves, you know, if you only see them in long sleeves, it's something to, you know, maybe occasionally have them pull up their sleeves. But the serotonergic medications can cause this abnormal platelet aggregation. You're going to see it more often in women, especially with older than 45 years old because they have thinner skin. This particular patient I'm mentioning to, she was only 20, so it can happen in younger people as well. You're going to be careful of the NSAIDs or anticoagulants if they're taking them. So if you see this sort of bruising, you might want to talk to them about if they're taking a lot of ibuprofen or something. Or certainly if they taking anticoagulants, it might be something you'd see. But you want to be more cautious if they have liver cirrhosis or failure if they have this type of presentation. So, there are a couple things you can do. You can add a proton pump inhibitor to it, such as omeprazole. And this would be something that you could get, over the counter. I'm not sure what dose, Dr. Pat.
Whatever it is.
He said whatever the dose is over the counter. So omeprazole, or you can use a non-serotonergic antidepressant, switching to something like Wellbutrin. So Abdullah said 20 milligrams. Okay, so 20 milligrams of omeprazole. The other thing is you don't have to do anything about them. You can suggest that they wear long sleeves. So in this, again, this particular patient is 20 years old. There was no really good cause to have her stop the medications. And so she started wearing long sleeves. That's not just to hide it, but it's to, protect it from more scraping and bleeding. So this is something you don't have to treat specifically, although you can. So low serum sodium is going to cause a swelling of some cells, and usually it's in the first month of treatment. The more serotonergic the medication, the higher the risk. So what happens is the ADH is lowered so that people just keep losing the sodium. The mild symptoms here, so the higher risk of female, underweight, smoking, diuretics. So there's going to be mild symptoms just of headaches, nausea, fatigue, restlessness. That's with these lower serum levels between 135 and 120. And you can run those labs if you're suspecting that. And then the more severe headaches, confusion, brain edema, coma, death. So clearly, if we're talking about serum levels within the severe range, you have to do something about it. But in a lot of these cases with low serum, there's not much to do. They still need to be on the medication. So the only thing that's really, so you're going to order those electrolytes. And in mild cases, the only two treatments for it are water restriction or just to not treat. Water restriction is very uncomfortable for the patient. They're really not particularly willing to do it. And then moderate cases, again, send them to the primary care to figure out if there's something the PCP can do. Severe cases, that's a medical emergency, the coma issue. So the highest risk is going to be in fluoxetine. That should have been on the slide, but that's more serotonergic. So you've seen QTc interval prolongation, am I correct, in other classes? Yes, okay, so I won't go into it very long, but as you know, this is a fatal form of tachycardia. It's something you absolutely have to do something about. It's dose dependent, and you're going to see it more in tricyclics, citalopram, and quetiapine. In fact, citalopram, I believe, was fairly recently changed in terms of the dose, right? So there are recommendations now that it's not over 40 milligrams. For citalopram, it used to be higher because of this potential of happening of heart attacks. And so if, obviously if they have heart conditions, I mean, frankly, this would be the kind of patients I'd say, if there's any kind of heart condition, I'd say, why don't you go to your primary care? Let's get a baseline EKG for almost everybody, for me as a psychologist. But if prescribing, but you really want to get a baseline EKG for high dose tricyclics or citalopram. And then if you're seeing the sort of interval of greater than 450 in male or 470 in females, then you need to switch medications. So you can see the pictures, and again, you've had this in other classes. So suicidality, see, how often would you ask them to repeat the EKG? I'm getting confirmation.
Okay, I'll answer.
Okay, Dr. Pappel answered that by text. I don't know the answer. So the black box warning of suicidality for 25 years old, and I haven't seen this, but Dr. Papp has seen it multiple times. Well, it really does provoke a suicidal event. There is controversy in that, because some of the suicidal, when they originally made that black box warning, some of the suicidal thoughts they coded for, were fairly benign. So there's controversy within the community about how much of a risk that is. So before, if you've ever seen the graph about it, that before 2003, there were more prescriptions written for teens antidepressants, and there were lower teen suicides. And after 2003, when this black box warning came on, the prescriptions written went down and teen suicide went up. Now, whether the cause it, what the correlation is, don't know, but it's just something to try to think about, that just because the patient is less than 25 doesn't mean you shouldn't treat them. So you want to avoid tricyclics, of course, because of the suicide risk with tricyclics. And if you've got to think about that cost-benefit risk ratio with the 25-year-old, but you're going to monitor everybody, of course, for suicidality, but particularly those that are 25 years or less. And particularly if you got that agitated, depressed state, that's that lift that can happen and just gives them that energy to kill themselves. And we see that as psychologists as well. So, okay. So we got the answer about the EKG, that it should be repeated yearly. But if it's abnormal, then you'd want to repeat it. Okay, just a black box warning about this suicidality in patients using. So it says the risk of suicidal thoughts of baby with antidepressants used in patients over 24. So, okay, I want everybody to see this. And did you cover this in bipolar, the Stevens-Johnsons from Lamictal? Yes. Okay. So I won't go over it again, but this is the one that you need to know, you need to be aware of, and you need to warn your patients about it before you prescribe it. Warn them to stay out of the sun. Dr. Papp just recently had a patient that ended up in the hospital because he had not, listened to him about staying out of the sun. So it's a great thing to just get a little, have them just send you if you're unsure, have them send you a photo of it, and you can kind of look at what's going on. But if you're at all unsure, send them to the ER, and then you have to taper down off the medication. So even though you've seen this before, it's so important. But here's the one thing to remember: it's not just Lamictal. There are other things that are probably problematic. In fact, I have to say I have a family friend, and she died from ibuprofen. From Stevens-Johnson, and so it can happen with other medications. So any rash. So that question that we originally had about, can't remember the name of the patient, Maria, I think. I can't remember. Anyways, she said she had a rash. Other things can cause rash too. So it's not just lamotrigine. So here's a little pretest. So which of the following statements statements regarding serotonin syndrome are true? A, it generally presents within 24 hours of starting or changing the therapy. B, generally presents 48 to 72 hours of starting or changing therapy. C, includes a triad of mental status changes, autonomic instability, and abnormalities of neuromuscular tone. Or D, A and C, or E, B and C. So do we have a poll, Hayden? It looks like most people are answering. Okay. Okay, so let's go on. Looks like everybody's getting it right. So have you covered this in another class? No. Well, it looks like everybody got it right. The answer is D. There's a post-test, but I'm going to tell you right now because you all got it right. He said, yes, it generally presents within 24 hours. And it includes this triad of mental status changes. So if you haven't had it before, Arnold said, yes, you've had it before. So have you covered serotonin syndrome in another class in this part of this program? Oh, 20 years ago. Okay. All right. So good. You remembered. So no, it needs to be covered in this class. And so before we do that, I'm just going to talk a little bit about antimuscarinic toxicity. You're much less likely to see this, but it can happen. So you're going to see it in tricyclics, paroxetine, diphenhydramine possibilities, and mild symptoms are going to be more likely in slow metabolizers. The elderly, remember, the elderly got to watch out this sort of thing. 2D6 inhibitors in other parts of their medication regime, and the dry mouth, constipation, urinary hesitance are sort of the mild symptoms of this. And there are ways to sort of mitigate those sort of things like dry mouth with things like different kinds of can't remember what's it called, that mouth that helps with dry mouth.
I remember.
Neither of us can remember. Anyways, so you can mitigate those sort of mild symptoms, but if toxicity is really you'd see it it's not cottonmouth. I'm thinking of a medication or over-the-counter medication that helps with dry mouth. Yes, Biotine, that's it. Thank you. Biotine can help with it. So toxicity is, so if somebody's going to overdose with a tricyclic in particularly, or with an elderly with the high doses of it, or diphenhydramine and another 2D6 inhibitor, the symptoms are going to be very rapid. They're going to be 24 hours, just like serotonin syndrome, but it's mad as a hatter, dry as a bone, blind as a bat syndrome. Which you've probably seen in one of your other classes. They've got this agitated delirium, and then they're just dried out in all parts of them. The little pinpoint pupils, still have normal muscle tone and reflexes. Note there's a difference between this and the serotonin syndrome in terms of the muscular tone. They've got urinary retention, reduced bowel sounds. So this is a medical emergency. You are not going to treat this in your practice. You're not even going to think about saying, yeah, why don't you come on down to my office and I'll have a look at you if they have this. They're going to the ER. So serotonin syndrome, and so at least when I took these courses, they were put fairly closely together just so you can really distinguish the two of them. So there's a variable onset, but remember most, so if it's 25 hours, you're not going to say, well, this isn't serotonin syndrome. Most are going to present within 24 hours of either starting or changing a therapy. The resolution is fairly quick, from hours to days. So you're going to see this agitation and muscle rigidity, tremor, restlessness. They're not going to be able to sleep. Dyskinesia. It's this all sorts of CNS and neuromuscular issues that go along with it. And there's I think I put it, there's this, at least the video was last time I looked, of the ocular flutter. That's a fairly subtle little look, but in this particular patient at the bottom of this slide here, the video, you can see what it's going to look like with the ocular flutter. They've got nausea, vomiting, and then this sort of the key thing here is this autonomic instability. Their temperatures unstable, chills, hyperthermia, respiratory distress. These are not well people. So again, you're going to think ER for this group of patients. So here's a nice little slide for you about the different differential diagnosis of these two different things. So we're going to look. There's treatment. There is treatment for each, but basically it's going to be done within the in the hospital, and you're going to withdraw the substance if this happens. So the key is you want to look for this sort of unstable temperature that particularly happens in serotonin syndrome, and then this mad as a hat or dry as a bone and the antimuscarinic toxicity. Well, that's a bad slide. Sorry. It looks very blurry, at least on my computer. This is the standard sort of diagnostic criteria for serotonin syndrome that you would see in almost any literature. Pathways that are going to increase the serotonin transmission are numerous. So it's going to be inhibition of serotonin uptake, so with the SSRIs and SNRIs, inhibition of serotonin metabolism, such as the MAOIs, increased synthesis from stimulants, increased serotonin release from stimulants or psychedelics, opiates, activation of serotonin receptors such as lithium, migraine, or inhibition of certain enzymes. So you can't just think serotonin syndrome is that you didn't give them to SSRIs. It can be from a variety of different things. That's why you have to be pretty careful and continue to monitor the patient about how many medications that they're taking. So a multitude of drug combinations and medications can really increase this. So here's just a sample list. I've seen a number of different lists of this, the kinds of things that are going to cause serotonin syndrome. We can add now on spirulina as one of the things that will increase serotonin. So even one of these little over-counter quercetin will do it. So clear red signs, or something like St. John's wort, or if you're adding another antidepressant, like you're not going to give an MAOI with SSRI ever, but trazodone, you often see our mirtazapine as some sort of adjunct. So if it's given in higher doses, certainly it can get it. But you want to think about medications that you're not prescribing. You want to think about over-counter things that they're taking, and you want to think about illicit substances, and particularly migraine medications. And I think Dr. Pat mentioned it as being something, if you have a patient, and migraines come very frequently with depression, you want to think about querying your patient about what kinds of medications they're taking for their migraines. So serotonin syndrome, you're going to avoid it at all costs. And then whenever a dose is increased, you're going to watch for it. Educate the patient about everything that they're taking. And the single-use pharmacy, which you've heard over and over again, is important. The washout period. So Dr. Papp is going to talk about the washout periods in the last slide session. So you're going to learn how to cross-taper, and to have washout periods for the MAOIs. And you need prompt assistance to the ER. This is, again, not something that you're going to manage in your office. So here's just another little slide. I think it's a nice one because it says, so these mild, you might see this in your office. These lower level ones by this time we're in the hospital, hopefully. So you've already got this one right. So we're just going to switch. So I have two cases that I'm going to only go back to if we end up ending early, which we will not, is my guess. But if you have at all interest in these two cases, I am happy to, after class, if you want to look at them and you want the answers for them, I'm happy to talk about it. Otherwise, we're going to move on to Dr. Papp's next lecture. So are there any questions about what I've covered?
So you're not going to ask these questions?
No, I'm just going to move on because these are long discussion questions. So I'm going to come back to them if we have time. Okay?
Okay.
All right. So we're going to go to Dr. Papp, and we will take a 15-minute break about 1:15, somewhere in there. Okay?
1:15?
Excuse me, 2:15. Is that correct? So we started at 12. So
2 o'clock.
At 2 o'clock. Okay, whatever people, so about, 2 o'clock, no. So we're going to take,
2 o'clock. They say 2 o'clock. We're going to do 2 o'clock.
you say 2 o'clock? Okay, we'll do 2 o'clock.
Now is 1:45. So 15 minutes is going to be 2 o'clock.
Well, I was thinking we were going to take a 15-minute break. So probably a little bit longer, but I'll let Dr. Papp be in charge of that one. Okay.
Okay.
Okay, so we're gonna stop whenever, just if we need to stop, Hayden, just simply say, please stop, and then we stop. Okay, so I need to put on my slide, so give me 1 second.
Doctor, are we getting 15 minutes break right now or after?
No, you said we're gonna break at 2, so we're gonna break at 2. I start
Oh,
talking.
okay. No.
But I somehow lost my connection or something. No, okay. I would like to say a few things about my presentation of the specific antidepressants. One of the complaints that received after last year's course that I spent too much time on the individual slides. They said that the slides were speaking for themselves. There was no need to read every line on them. People go and read the lines themselves. So that led to my decision, okay, so just not read everything on the slides, but read whatever I thought was the most important things on the slide. So if then this time it went a little bit too fast, I apologize, but again, that was the reason why I decided not to spend as much time on the slides this time as I spent the last time. So, and again, I'm thinking that also there's one of the thinking that these slides themselves are like a book, and you refer to them when you, let's say, answer questions on the exam. It doesn't mean that everything had to be said. But again, going over the slides so fast or this fast was a result of us getting complaints about not going over them fast enough. So we're going to talk about the specific presentations of depression as they are according to DSM-5, and the specific medication choices that we'll have to do with them. So with DSM, with melancholic depression, one of the main features of this presentation is the loss of pleasure in all activities. If you see patients like that, these patients are almost like flat, have a schizophrenic-like flat affect. They don't look at you, they almost don't respond to questions. There's very little modulation in either their psychomotor activity or their speech. Their mood does not respond to anything. They express profound hopelessness and despondency. And there are specific and typical vegetative symptoms like insomnia, most typically early morning awakening, feeling, especially in the morning, the depression is bad, that it might improve a little bit as the day goes on. There's severe psychomotor retardation and weight loss because there is a severe loss of appetite as one of the signs of pleasure. And if you may remember, yesterday I talked about how anhedonia is modeled by rats not liking glucose. So I guess that's the idea behind that liking eating is in a way a form of just being able to experience pleasure. It is the type of depression in which this pituitary adrenocortical activity is the most increased. That's when the dexamethasone test was used in the past, and again, just mentioning it for sake of interest. Anybody's interested in that. This is the kind of depression that is most likely going to require inpatient treatment or ECT. Some medications are perhaps more likely going to be helpful with this type of depression. These are called, unofficially, of course, anti-melancholic medications that you would put on these patients on once they stop the ECT after the course of ECT is finished, or even during the course of ECT. And these would be the cipramine, mirtazapine, bupropion, and high-dose SNRIs. Now, this is going to be a condition that no low dose of medication is not going to be helpful for. Because suicidality is so typical and so strong, and because the hopelessness and despondency is so prevalent, it is useful to put these patients on lithium for its anti-suicidal effect. If you're treating this patient, whatever medication for augmentation, you're going to choose activating agents like bupropion, amoxicillin, which is Strattera and not approved for depression, but you can use as an augmenter, or the cipramine. You can also use the amphetamine-based products like Adderall or Dexedrine, thyroid hormone, or modafinil. So these are all medications with different types of mechanisms of action, but they are all medications that are activating. This is the most biological form of depression. It has the lowest placebo response in studies and the lowest psychotherapy response. And just a quick question just popped to my head. If anybody knows what is the psychiatric condition that in general has the lowest placebo response? What is it? What is the psychiatric diagnosis has the lowest placebo response? And I'm taking out schizophrenia. Don't think about that. Anybody has any idea? Just waiting 15 seconds. Is an unofficial question here. Yes, it's OCD. Very good. That's the one. So this is catatonic depression. It is something they're probably not going to see unless you work at an inpatient unit. Catatonia itself is not specific to depression. It can be seen in other conditions as well, most notably schizophrenia, but sometimes also see them in different kind of brain disorders like brain tumors, etc. And it's a psychomotor disturbance that involves either a very specific and bizarre increase in psychomotor activity, or a complete opposite of that. What you see in depression is the kind where people are just not moving. You can see these people lying on their bed, on their pillow. You take the pillow out from under their heads, and they can continue to be in the same position for hours, for days. But if you move them specifically, you move their head or arms or any other body parts, then they let it move. You let them move it, and then they stay in that position. If everything works well, the next slide is going to be a video of that, but I'm not sure if it's going to pop up. Let's hope. It worked yesterday, but I'm not sure it's going to work today. So catatonic depression is usually the end state of a very severe major depressive episode, usually of the melancholic type. In depression, it is always the decreased motor activity type. It is very rare, so rare that usually it leads to case reports. It always requires hospitalization. In fact, sometimes it happens while the patient is hospitalized with, let's say, melancholic depression and not responding to treatment. It just gets more and more depressed, and eventually one morning they find him being catatonic. ECT is typically the only effective treatment of depression. The catatonic depression, the catatonia itself, can be resolved with intravenous or intramuscular lorazepam. It's actually very interesting. I have seen it once as a resident. The patient, a catatonic patient, is motionless, and they giving him lorazepam, and within 30 seconds, he was like back to normal as if nothing happened. And like 20, 25 minutes later, the catatonia came back, and he slowly went back into this completely unmoved state. Eventually, he ended up getting ECT. So catatonia as a symptom can be relieved, but obviously it's because it's a result of depression. It is going to come back until the depression is itself treated. And it is the anti-melancholic medications that you would prefer if they recover from this catatonic form of depression after the ECT. So let's see what you're going to see in the next slide. Okay, so it's not working. This is supposed to be an embedded video, which it works if I look at my case on my PowerPoint, but apparently it's not working here. So what you need to do is go to, if you want to see this video, go to Vimeo and search for catatonia, and it's going to be one of the first few videos that you're going to see. It's pretty interesting.
Just tell them what happens in the video.
Okay, atypical depression, and this is going to be this slide before we break at 2 o'clock. It is a historical term. There's nothing atypical about it. Atypical in the sense that it's not, when melancholic depression was considered to be typical, then atypical, that this kind of depression was considered to be atypical. Atypical because it retains the mood reactivity on, as opposed to melancholic. There's weight gain and hypersomnia, there is increased sleeping instead of weight loss and loss of sleep. So that's atypical about it. But again, as depression, it is probably one of the most typical depression forms that you're going to see. So don't be confused by the name. It's a bad name, but that's why it's called. Something called leaden paralysis is considered to be a one of the major symptoms. It's a heavy leaden feeling in arms or legs. People don't feel like doing anything. They don't feel like moving. They feel like tired all the time. And some thinking states that this is what's diagnosed as chronic fatigue syndrome. There is not actually, I mean, basically chronic fatigue syndrome is just naming a syndrome, so naming a symptom, so it doesn't explain anything, but it may be a symptom of depression in this kind of a typical presentation. It is the one that's most often comorbid with other axis 1 diagnosis. It often alternates, this should be an S, I'm sorry, often alternates with mixed episodes. So people are in a mixed depressive episode. Dr. Myers described in great detail yesterday. And so they go back and forth between this atypical and mixed, in atypical or mixed states. And there's a high incidence of family history of bipolar disorder. And again, remember, mixed states have some bipolar flavor to them. So it is in that bipolar spectrum kind of things that you can imagine. I'm going to share the link in the break. I'm going to find the link and then just put it up. In earlier times, it was considered that MEOs were considered better than TCAs. MEOs were considered the treatment of choice for atypical depression. When SSRIs came to be used in psychiatry, then MEOs, nobody did studies comparing MEOs with SSRIs anymore because nobody used MEOs anymore. So we don't know whether SSRIs or MEOs would be better for treatment of this condition. Most people would treat this condition with SSRIs. Again, treat according to the patient and side effects, as Dr. Myers explained before. So this is a patient in which you want to avoid medication that cause weight gain, the reciprocity and amortazepine. Again, avoid medications that would be causing more sleep. Officially would be MAOIs because of these early studies, but in clinical settings, you're going to be using SSRIs. If there's hypersomnia, you may want to use modafinil. The fatigue, the daytime fatigue, it will be relieved pretty effectively with it. The problem is that there is some tolerance that develops to long-term use of modafinil. Not addiction, but tolerance. Okay, so let's break for how long?
I don't know, whatever they want us to do.
How much should we break for? 15 minutes?
That sounds good, Doctor.
Okay, 15 minutes, like at 2:15. So let's talk about another specific form of depression, now called peripartum depression. A certain number of women experience their first major depressive episode in this period, and actually half of what's typically customarily called postpartum depression actually begins prior to delivery, sometimes a few hours, sometimes even a few days. So it's not necessarily postpartum. It's a depression that affects not just the person who has it, but also the baby, the newborn. The ability to care for the newborn is severely compromised, sometimes to a degree that the newborn's life is in danger. It is often accompanied by anxiety or panic, and severe forms can have psychotic features. If the depression is psychotic, then it increases the risk of recurrence considerably. Up until a few months ago, only these two points applied. The general pharmacological treatment guidelines combined with pregnancy, lactation considerations. So again, depending on the severity of depression, you were treated with antidepressants at different levels. And if it was very severe, then you were treating it with ECT. If the first depressive episode, if the woman's first depressive episode, so if the woman is in this category, so the first episode is peripartum, then the antidepressant treatment should be continued longer than typically after the first episode, so at least for a year. And the first episode, sometimes the recommendation is that you can try discontinuing it after 6 or 9 months, but certainly not if that was a postpartum depression, peripartum depression. As of March of this year, as I mentioned in the previous slide, now we have this new medication available for the treatment, specifically peripartum depression, and it's an inpatient long infusion treatment. Seasonal depression. The features include the onset and the remission of the episode at characteristic times of the year, and is typically when the illumination, the daytime illumination begins to be reduced or reaches a certain level, or it gets into actual winter, and then it begins to improve in spring or summer. But there are a few people who have become depressed in the summer and get better in the winter. I wouldn't say, that's certainly would be atypical, but it's not unheard of. The presentation itself resembles atypical depression with loss of energy, hypersomnia, overeating, etc., carbohydrate craving. The more north latitudes a person lives, the more likely to get this form of depression. And the specific treatments are bright light therapy with or without antidepressants. The antidepressant with other than serotonergic activity seem to have preferential effect. Sometimes melatonin and ramelteon, which is Rosarum, can improve the quality of sleep in seasonal depression. And for the daytime fatigue, you can again try modafinil. Psychotic depression features delusions or hallucinations. And how is it different from schizophrenia? First of all, that depression comes first and then the psychotic symptoms begin to appear later. And also that the psychotic symptoms are mood congruent, which means that the psychotic content is consistent with the typical mental content of depression. So it has to do with guilt and inadequacy and being diseased or death or excuse me, impoverishment or deserving punishment. The mood incongruent psychotic features would be more typical to schizophrenia. So let's say the FBI is watching them, or the devil is chasing them, or there are cameras in the bathroom. If you see that in a depressed person, then it could be a primary psychotic disorder. It's certainly more likely to be a primary psychotic disorder than if the delusions and hallucinations themselves are mood congruent. And also hallucinations are not as prevalent or as strong as in schizophrenia, and almost always exclusively auditory, and it is virtually never visual. Whereas in schizophrenia, you have kind of number of visual hallucinations. So be careful not to mistake it for schizophrenia or schizoaffective disorder, and this is one of the ways of making that distinction. So look at the mood incongruent or congruent features of the psychotic thoughts. And again, also the temporary relationship between the onset of depressions and the onset of the psychotic symptoms. But again, don't forget that psychotic people can become depressed, including when they get out of psychosis and they realize that they were psychotic. So the insight into being schizophrenic can induce can induce depression. Then you treat it as regular depression, but that would not be a psychotic depression. That would be a major depressive episode in somebody who's psychotic. If it's severe, again, consider ECT. Pharmacotherapy is different in the sense that if you have a patient and you see it for the first time and has psychotic depression, then you start both the antidepressant and the antipsychotics at the same time. You probably don't want to start low and go slow, go a little bit faster in both, and continue the antidepressants really for years. You can slowly try to taper off the antipsychotics when in remission, but continue the antidepressant for years. And if psychosis returns, and if it continues to return, then you can consider schizoaffective disorder as a diagnosis. Depression with anxious distress used to be called agitated depression, which I think is a better term because it's more descriptive. So this is a patient who is overwhelmed with worrying, feeling keyed up, tense. There's a sense of excessive loss of control, doom and gloom. You see a patient and he's in front of you in a chair, and it looks like that he is just about to take the most difficult exam of his life. He's wringing his hands, is shaking his legs, his face is contorted with anxiety. And at the same time, of course, it also expresses symptoms of depression. Usually there is a lot of anxiety about losing their livelihood, that somebody's being ill. There's almost psychotic level of anxiety about things that might be happening. I had a patient recently who was convinced that their house had some kind of a major structural problem, and they would have to get in contractors and get it remodeled for hundreds of thousands of dollars. And the relatives assured me that there was absolutely nothing wrong with the house, and this patient was worried about it all the time. He was pacing, he was shaking his legs, he couldn't sleep, he was so anxious about it. And the entire feeling of anxiety and focus on this particular fear went away once the depression was treated. Because it's a high energy form of depression, it is associated with a high suicide risk. It's also difficult to treat. It's said to be a long duration of illness, and so treatment resistance is quite frequent. Because it's an agitated, because it's a high energy type of depression, try to avoid bupropion, favor serotonergic medication effects, can combine it with sedating effects, quetiapine, aripiprazole, also because of some antipsychotic effect. And like I said, that the level of anxiety is almost psychotic. It's just go to the border of being psychotic.
There's some questions.
I see there's kind of conversation going, but I don't think it's for me.
It says if you could prescribe TMS before you try 3 different antidepressants and CBT.
Okay, so is this question to me, you could prescribe TMS before you try different antidepressant, or this is the person who asked about TMS in a state to everyone? Okay. TMS is not covered by insurance unless you had at least one treatment failure. That's how it's approved by the FDA. PMDD, okay. It's a very typical cyclic pattern of mood and physical symptoms. So again, don't forget mood and physical symptoms. Irritability, depression, fatigue, and the physical symptoms are bloating, breast tenderness, headaches, and general achiness. The typical treatment is serotonergic medications. VFX is venlafaxine. Again, low dose venlafaxine is serotonergic. St. John's wort can be used. And ketamine is a new idea. Ketamine timed to these hazard zones, as it's shown in this picture, that can prevent the onset of dysphoria, premenstrual or perimenstrual dysphoria. So there's no point giving ketamine in this phase, but ketamine here before or just after. You can dose the serotonergic medication in 3 ways. You can either give it steadily. You can give it only premenstrually, 5-7 days before and during the period. So basically in this period, and then stop giving it. Or you can give as continuous low dose with premenstrual increase. So let's say give the person Lexapro, escitalopram, 5 milligrams on a continuous basis, and then the week before period, the patient increases it to 10 milligrams.
So she's asking a question.
Well, that's a very good question. It is, nevertheless, it is a medication that seems to be having an immediate effect in this particular kind of depression. And yes, it goes against the idea that antidepressants need to work, need to be in a body for a long time for them to work. But this is a different kind of depression. Antidepressants seem to be working in this manner. I will not be able to explain you why, but this is in fact the case. And again, you're not giving high dosages. Low dosages seem to be effective. These are different kind of nutraceuticals that apparently have some effect. The patient should avoid caffeine, alcohol, salt, sugar, smoking. They seem to improve some of the behavioral and physical side effects. And these specific physical side effects, you should not try to treat. You should leave it to the gynecologist or a primary care physician. Are there specific SSRI that work better for PMDD? So the ones that have the ones that's used are pretty much anything. The Prozac is recommended, but the problem with Prozac that it has a very long half-life, so you almost like you're never without Prozac if you give someone Prozac once for a week monthly. The OHX officially recommended is a low dose venlafaxine, but any SSRI like Lexapro, sertraline in low dosages would be one that's not recommended. Okay, we have a little quiz here. An 80-year-old woman without past psychiatric history is suffering from a left-sided stroke. Since her stroke, she complains of an absence of pleasure in anything that she formerly enjoyed. She describes frequent crying spells, sleeping more than usual, a decreased appetite with weight loss, and feelings of hopelessness and helplessness. She admits to passive thoughts of suicide without plan or intent. She is on multiple medications for diabetes, type 2, high blood pressure, pain, and urinary cystitis. Which would be your antidepressant of choice? So before you answer the question, think about what type of presentation it is, what specific psychiatric and depression presentation it is, and then try to answer.
Doctor, I also noticed that the last item on the poll is different a little from your option.
Yes, okay. And I apologize, the 0 should be a dash.
200 points.
Okay, so 2 to 4 weeks.
And the dosage is 75. You change the dosage is different.
Yeah. Yeah, I'm sorry, I changed some of the questions in the last moment, and it's I forgot to communicate that to you. I'm very sorry about that.
No problem.
Can I give you a little more time because this is really complex question. You have to think about the case. Okay, so she's depressed, but she's an 80-year-old woman, and she's on multiple medications. So these are important points.
So what, 0?
Yeah, I apologize again. The 0 should be a dash down here. It's my mistake.
And they're asking again about the dosage, so explain it, which one you want.
Yeah, so actually it doesn't really matter. You can answer either of the two questions, either one on poll or one on the question. Actually, it's not going to make a difference.
It's 300 milligrams starting.
Yes, so most people answered correctly. That's really the best choice. Again, when you answer these questions, there are answers that are the best choice, and they're the second best choice, and the third best choice. And you can make case for other choices, but you always pick the best choice. So this is the best choice. She's an 80-year-old woman. She takes on multiple medications. Of all the medications that could be used in some cases, this is the one that is going to be the least problematic in an 80-year-old woman on multiple medications for diabetes, high blood pressure, pain, and urinary cystitis. This is the medication with least amount of side effects, the least amount of interactions. It's not going to cause any problem with somebody who has diabetes. It's not going to increase or decrease blood pressure. It's not going to cause any kind of urinary hesitancy, etc. Okay, so of all the choices, this is the best choice. And whether it is 300 milligrams ER, that would be too much. That's why I changed it a little bit different. But again, venlafaxine is just not something that you in general want to prescribe at 300 milligram a dose, whether you start at 75 or whether you start at 300 for someone who is already suffering from high blood pressure, because it's one of the possible side effects of that medication. So the best choice is D. Any questions? Okay. So let's look at the depressions that have comorbidities, because most people with depression have comorbidities. And remember that was the reason behind this huge production that's called the STAR-D study, that you can have clean depression patients in pharmaceutical studies to get medication approved, but the majority of people in real practice are not like that. So you're going to see these type of patients in your practice more often than patients who do not have comorbidities. So let's look at depression and pain. Depression, pain, and sleep are in a triply reinforcing positive reinforcement cycle. Depression worsens insomnia, insomnia worsens depression, insomnia worsens pain, pain worsens insomnia, and pain and depression again worsen each other. This is one of the most difficult forms of depression to treat. The depression is partly physical and partly psychological due to the demoralizing nature of chronic pain, which itself has its many aspects, not just the fact that the patient is unable to do whatever he or she like to do, but the nowadays really humiliating way of getting pain medications. Everybody is trying to get pain medication is seen as a drug addict. The hassle of trying to get the medications, etc. So these patients are usually angry. These patients are hopeless, demoralized, and this can be very, very difficult to treat. Lower back pain is the most frequently associated with pain, with depression. and they very strongly mutually reinforce each other. And in addition to am I missing something?
No, I answered this one, but I was just looking at it.
Don't forget, these patients are on a whole bunch of other medications, such as muscle relaxants, GABAergic medications, gabapentin, baclofen, Flexeril, and not unimportantly, other antidepressants like duloxetine or tricyclics that others prescribe for their pain. In general, you should favor SNRIs because that's what the pain doctor would prescribe anyway. But again, make sure that you understand that you're not treating pain, you're treating the depression with hope that the effect on pain is going to be a secondary positive effect, such as when you treat depression people who have insomnia, you give an antidepressant that can also help with insomnia, but you're not treating the insomnia alone. Here again, you're not treating the pain specifically, but again, you're trying to pick an antidepressant that at least some degree would or might help the patient with the pain as well. In situations like this, usually you have to tend towards higher dose ranges. Treatment resistance, failures, frustration on both sides is prevalent. And again, like I said, don't forget you're going to see these patients on SNRIs already, and they have been studied by other doctors. So let's say you see a patient coming to you on 120 milligrams of duloxetine that his doctor gave him for lower back pain, and he's still depressed, and it's going to be very difficult for you to pick another antidepressant or to figure out what to do. NDD comorbid with anxiety, as we discussed before, this is a very difficult kind of depression to treat. Of course, it has anxiety, agitation, obsessive ruminations, can be irritability, aggression, and suicidal ideation. This is one of the strongest factors in making depression treatment resistant. So how would you treat it? Luckily, all serotonergic medications can be used both for treatment of anxiety and depression. Some of them are approved for both anxiety and depression diagnosis. At the beginning, you want to use benzodiazepines. Now the question is which benzos to use. It has gone through some permutations during the years. Theoretically, the anti-anxiety benzo with the antidepressant effect would be alprazolam Xanax. Xanax has its own problems. It is probably the more addictive benzos that are on the market. One of the most liked benzos that are on the market, so people may, push for that. Don't forget that one of the problems with Xanax, it's a very short half-life, so it goes in fast, gives a euphoria effect, and it goes out fast and gives you a withdrawal effect very fast. It has, luckily, an extended-release form. It's called Xanax ER, and it has generic forms available. So if you want, you can prescribe extended-release Xanax to patients on the first several weeks, and eventually you can taper off. Other medication, other benzos that you may want to prescribe, pretty much any other, lorazepam or diazepam. Clonazepam is the benzodiazepine that is probably the most pro-depressant. Some people have some depressant effect from clonazepam, usually not very significant, but sometimes noticeable. So maybe you want to avoid that benzodiazepine. Buspirone, which is Buspar, is an obvious augmenting agent. bupropion should be avoided because it's activating and any other kind of activating medication. Unless the depression is very severe, you should start low, go slow, and start even lower and go slower than usual. And it especially applies to fluoxetine that can be activating in the first few weeks. Suicidality was covered by Dr. Myers, so at this point I took it out of the slide. MDD, comorbid eating disorders. Anorexia nervosa is a totally separate diagnosis. I'm not going to go into that, but obviously it can come with depression. If you treat a person who has anorexia, truly diagnosed anorexia nervosa, who has depression, you will not use bupropion because it increases the seizure risk and can also reduce appetite. You can choose, if you want to choose antidepressant, probably the first choice should be mirtazapine, which would increase appetite. And again, you can augment with appetite-enhancing neuroleptics, and this time probably olanzapine would not be a bad choice. In fact, it is used for that, and quetiapine would be another. In binge eating, there's still seizure risk, so you have to avoid bupropion. And here you have to also avoid mirtazapine because it's an appetite increaser. And you would use SSRIs, actually fluoxetine. Prozac is FDA approved for binge eating disorder. And I'm not covering binge eating, but there are specific medications other than SSRIs approved for binge eating. Binge eating or bulimia, binge eating. MDD, comorbid substance abuse. Now, this is a huge topic, and I will, this is just a summary slide. And again, don't forget that again, there's a bi-directional connection between substance abuse and major depression. You have to treat both at the same time. It's going to be very difficult to treat just one if both exist. It's just the whole idea behind the co-occurring disorders clinics. The general treatment guidelines apply, again, with favoring or disfavoring different antidepressants according to the symptoms that the substances themselves cause. So with alcohol, there's an increased seizure risk during withdrawal. So in general, you should avoid giving bupropion for alcohol-related depression. You treat the depression with bupropion, patient feels better, feels motivated to stop the alcohol, and then they get a seizure. So that's not the right medication. It's not the best medication to start. Also avoid very sedating antidepressant and avoid, of course, using benzodiazepines and Z-drugs for insomnia. So basically favor the plain SSRIs. People on high dose methadone, whether it's for treatment or addiction, you have to avoid medications that have problems with QTC prolongation because methadone itself has the same problem. So we would avoid citalopram and TCAs. Tramadol, tapentadol, dextromethorphan, these are medications that can then have some pro-serotonergic effects. Some of them actually, serotonin reuptake inhibitors themselves, which is tramadol. You have to avoid all MAOIs to treat patients like that with depression. MDMA, again, for the same reason, you should avoid all MAOIs and St. John's wort, which can cause serotonin syndrome, as well as stimulants, which can also cause serotonin syndrome. Methamphetamine. Depression is very frequent, and again, treating is going to be very difficult as long as a person is an active user. The bupropion is interesting medication. An immediate release bupropion can be snorted. So as I mentioned in one of the slides, do not prescribe regular bupropion to someone who has a history of methamphetamine or amphetamine addiction and is depressed, because they may be tempted to snort it. On the other hand, the extended release bupropion, because it has a similar effect to amphetamine, methamphetamine, can plug in the same holes that the methamphetamine leaving the system would leave. So that's the kind of depression, the methamphetamine or amphetamine withdrawal depression, that bupropion is perhaps more specifically can help. Now, this is the theory. You know, you try it, sometimes it works, and it doesn't work, then just feel free to use the regular SSRIs. With cocaine, again, SSRIs, interestingly, can facilitate convulsions. And bupropion co-administered with cocaine increases its lethality on cardiac toxicity. And with PCP, ketamine, hallucinogens, marijuana, there is no reliable information as to which antidepressant should be favored or disfavored. Again, hallucinogens in general have serotonergic effects, so there is a possibility that serotonin syndrome may occur, but it is theoretical, and I am not aware of any case reports of that. Depression and pregnancy. It's a relatively old data, probably its number is even higher, but about 70% of pregnant women take at least one prescription medication. That's not necessarily an antidepressant, but probably a large percentage of that is an antidepressant. Theoretically, all female patients should be asked about pregnancy before you prescribe a medication, whether they're pregnant, of course, and whether you're planning to be pregnant or whether you're using protection against. The risk of major depression is the highest during pregnancy and the postpartum period. So if the woman becomes depressed, then you will have to treat it. And the effects in the baby are rare. The absolute risk is really small. Obviously, you cannot have placebo-controlled studies with that, but there is no long-term population-based cohort studies that would show any kind of major developmental disorder developing in women who take antidepressants, the usual, SSRI antidepressants during pregnancy. One of the things that occur during pregnancy is that the metabolic activity of the liver increases. So there's a possibility that the woman takes an antidepressant and is stable. The antidepressant the dosage becomes insufficient because the metabolism of that particular antidepressant would increase during the pregnancy, and therefore the dose may have to be increased to maintain the same blood level. There used to be these pregnancy categories that were helpful, the A, B, C, and D categories, and I used to put them on in the slides. But as of 2015, these categories are deprecated. They are not put on these new medications. For instance, Trintellix is not, you will not see any category, pregnancy categories. Instead of that, you're going to see these box or this statement on the medication and product inserts that instruct you to go to this particular website and check out what information is available about the medications and pregnancies. Nevertheless, there is still some information that's available because of the past history of this FDA labeling of medications. So you still remember that paroxetine is category D. Still remember that lurasidone is category B. And you remember these things and you keep them in mind, but officially you're not using them anymore. So it actually became a little more difficult to make a decision. Requires a little more research on your part. But again, the idea is that with most of the SSRIs, it's probably you do more harm to discontinue them in a severely depressed pregnant woman than continuing them. Untreated depression in pregnant women lead to a higher risk of premature labor or spontaneous abortion, a higher risk of reduced head circumference in the child, birth weight, a disorganized sleep pattern in a newborn, and reduced attachment and bonding with the child after birth. Animal research shows that the maternal stress, untreated stress, can affect the programming of the fetal brain. And this just seems to be the triggering factor, hypercorticolism. And if you remember from yesterday, it may have to do with the reduced GABAergic activity on the pituitary, hypothalamus pituitary axis, and that's what brexanolone, Zulresso, is correcting when it's being used in the treatment of postpartum depression. But again, the high cortisol level, that certainly the mother gets into the fetus, and it can have these negative effects. So we saw the effect of antidepressants in pregnancy. Sorry, the effect of depression in pregnancy. Now let's see the effect of antidepressants in pregnancy. So like I said, there's no unequivocal findings. There are some short-term perinatal effects. There's some withdrawal effects in the newborn. There's a mild respiratory distress, jitteriness, decreased muscle tone. Right after delivery, lasts for a few days, and then it goes away. There are some long-term studies that were done, and like I said, there is no lasting adverse effects or sequelae on neurodevelopment that was ever found. There's no signal in any of the post-marketing data on the now adult children of women taking antidepressants during pregnancy. And then finally, remember these, the relapse rate of discontinuing antidepressants during pregnancy is really high, and you get much more, you do much more damage to a woman relapsing into full-blown depression during pregnancy than continue to treat the depression. So these are the general guidelines. Of course, careful consideration. In mild cases, if there's no strong indication, then you can discontinue the medication and you can prefer non-pharmacological strategies. So psychotherapy, nutraceuticals, like the natural building blocks of serotonin metabolism, but not St. John's wort because it is considered an antidepressant, and then light therapy. If there's clear indication but it's not currently symptomatic, then taper it slowly before the first trimester. Of course, this applies to planned pregnancy, and restart in the second trimester. And in severe cases, or if there is a history of relapse, is a relapse when it was discontinued in the past, then don't stop it. And remember that ECT and TMS are non-pharmacological treatments that you can use in pregnancy for women who are severely depressed. And as lactation, just look at my slides. The choice is governed by secretion to breast milk. Paroxetine seems to be the SSRI is that least likely to be secreted. So consider switching to paroxetine during the course of lactation and switching back to whatever antidepressant the mother was taking after nursing is stopped. So Dr. Myers is telling me that we're supposed to break again.
Yes,
Okay, so 15 minutes, 10 minutes.
whatever they tell us.
Let's have a 10-minute break.
Sounds good, Doctor.
Okay, 10-minute break.
So I think you got some eating disorder stuff wrong. So you just sent
It is a bulimia and not binge eating disorder that is associated with depression, obviously with increased risk of seizures. So thank you. Let's continue. Depression and sleep. One of the most common problems with depression is trouble with sleep. Vast majority of the trouble is insomnia, and there can be some normal sleep, and sometimes it's hypersomnia in the so-called atypical form of depression. And again, I don't see my slide. One of the crucial thing to understand about sleep and depression, that there is the distinction between difficulty falling asleep versus a decreased need for sleep is one of the most important questions that you can ask when you interview a patient for at the initial in the initial visit, and if you don't make this distinction and treat someone decreased need for sleep, it's in a mixed state with an antidepressant or trazodone, then you can create huge problems for the patient and their environment. Now, different ways of categorizing insomnia can be initial, middle, and late, which is usually what's early morning awakening is. And late insomnia, there is early morning awakening is more common in melancholia. Hypersomnia is more common in atypical and bipolar depression. And most depressed patients have initial and or middle insomnia. And like I said, depression and sleep are a difficulty with depression, and sleep are a mutually reinforcing connection with each other. You are going to treat sleep with your depressed patients. So I presume that you have seen these medications before, and you had been treated in different previous presentations, but I just want to have this kind of a summary. And I assume that you know all these medications, what these medications are. If anybody doesn't know what these are, please let me know in the chat. So basically three groupings. There's the GABA-A, alpha-1 site agonist. These are the so-called Z drugs. The GABA-A benzodiazepine site positive allosteric modulators, the PAMs. And then the others, which is a mixed bag of things. Zolpidem or MDM was the first one. It has a relatively short half-life. Sonata or Zaloplan is the shortest, and Zopiclone, which is again an enantiomer of Zopiclone, which is available in Europe as a racemic medication, Lunesta. It has the longest half-life. They can all cause sleepwalking, which is one of the most scary side effects of these medications. Perhaps Lunesta is the one that's least likely. Lunesta is also distinguished by the fact that it's the least likely to cause rebound insomnia. Ambien and Sonata can both cause rebound insomnia, especially Ambien. Just a little anecdote that I like to tell about Ambien. I had a patient who told me that he got a summons from police station to go and testify in a case. And he went there and he said, I have no idea why I'm here. And said, well, you saw a crime and you agreed to come down and testify. And he says, I have no idea what you're talking about. So they showed him his signature on a piece of paper that he said, yes, I agree that I'm going to testify. So it turns out that he took his Ambien, went to sleep, got up around 1 a.m., decided in his sleepwalking manner to go down to the local 7-Eleven or some store like that, where there happened to be some kind of robbery taking place. He witnessed it. He talked to the police. He said, yes, I'm going to go testify, go home, went to sleep, and forget about the entire thing until he got the summons. So I would say this is the most extreme example, but you're going to have patients telling you that they ate overnight and there was crumbs everywhere, and sometimes they even go sleep eating, and that's known Ambien of side effects. I had known sleep sexing. Somebody had decided to have sex and induced his partner to have sex, and the next day he didn't remember that it happened. So Ambien can be a tricky medication. You always have to ask, and first of all, you always have to tell patients that this may be a potential side effect. I would advise you not to prescribe it to people who live alone, because nobody will know that they are sleepwalking. It is okay to prescribe it to people who live with others, but you have to tell them to get others, give feedback whether they think that they're sleepwalking or not. Somebody made phone calls, that's right. So you can do all kinds of things. I know a patient who finds herself on a bus going someplace in the morning when he woke up from his Ambien-induced sleep and had no idea how he got on the bus and where he was going. So the benzodiazepines are similar effect to the Z drugs, but with added risk of dependence. If you want to use them, then use diazepam or lorazepam. These have mid-range half-life, so there is lower risk of dependency, but also lower risk of negative grogginess. Clonazepam is a medication that can cause, there's some risk of increasing cleft palate in pregnancy, so you should avoid giving clonazepam to any woman who is pregnant. With benzodiazepines, a paradoxical agitation can occur in the elderly or people with TBI, so you really should avoid giving benzodiazepines to the elderly for sleep. That would include the Z drugs as well. And don't forget that benzodiazepines can be lethal in patients already on high-dose opiates. Even in the medium-high-dose opiates and medium-high-dose benzos taken together, the patient goes to sleep and may just die from respiratory arrest. Other agents frequently used, first of all, the antihistamines, the diphenhydramine, which is Benadryl, doxylamine, which is Prosam, hydroxyzine, which is Vistaril or Arax. Don't forget that diphenhydramine has also anti-muscarine effects, so people take too much diphenhydramine, they can have anticholinergic toxicity. Melatonin-ergic agents, melatonin itself, over-the-counter, Ramelteon, prescription. Sedating antidepressants, trazodone, again with the caveat of using these medications in bipolar. Mirtazapine in very low dose. The higher the dose, the less sleeping effect, because the antidepressants effect kick in, including the noradrenergic effect, and keep the patient up. Doxepin in the form of Silinor, which is you simply just should avoid, don't even think about it. And amitriptyline, which is Elavil, a very sedating tricyclic. Sedating antipsychotics you can use in situations where there's agitated depression or depression with some level of paranoia, for instance. Quetiapine, you should try to, in difficult cases, and olanzapine only in desperate cases. Okay, so quetiapine should not be your first sleep medication you go to in a patient. And then you can have different over-the-counter medication, valerian, kava, tryptophan, 5-HTP, and all these last two, you need to watch out for serotonergic interaction. Questions? There's a lot on this slide. So these are just clinical pearls that you should remember. All antidepressants may interfere with sleep onset. It is very useful. You have a patient who is taking antidepressant and has difficulty sleeping. Don't forget to ask, so when do you take your antidepressant? Many times patient will take the antidepressant at bedtime, and all you have to tell them, take it in the morning and they're gonna start sleeping better. You can avoid giving antidepressants like trazodone in bipolar. Remember, all antidepressants are RAM suppressant, except the Fazodone and bupropion. So when they stop taking it, there's a RAM rebound that can occur with increased dreaming. You can just tell patients, don't worry about it, it's going to go away. It is can be an annoying side effect, but it's definitely not dangerous, and it's not a sign of anything more sinister. As usual, try to address the underlying condition first, and only if it's not possible, or if it's very early in the treatment, that's when you should add sedating medications. Try at least one behavioral intervention in initial treatment, CBT or CBTI, as Dr. Myers mentioned, sleep hygiene, education, stimulus control, etc. Try to keep the treatment of insomnia specifically or separately from the depression treatment short. Encourage patients to use the medications PRN. Anybody who doesn't know what PRN is, let me know. Discourage routine nightly use. Patients will stop eventually, typically when the medication, when the depression is being treated and they start sleeping better naturally. And don't forget that all sleep-inducing medication, no matter what the mechanism of action is, starting from low-level Benadryl up to Mazepam, because they reduce alertness, can increase accident proneness, impair driving skills, and especially in the elderly. So you have to be careful about that. You have to be aware of that. In the elderly, some specific rules apply. You have to start lower, go even slower. Be careful with the sedating side effects because they are more significant in the elderly than in younger people. You should try to avoid highly antihistaminic medications. Favor SSRIs like escitalopram, sertraline, which have the least amount of interaction with other medications. But on the other hand, most medications do not, unless they're really, really very elderly, like in the 90s, would not require any kind of dose adjustments. Don't forget the comorbidities. Don't forget about the polypharmacies that these patients may be on. And don't forget, remember, depression can be a symptom of incipient dementia, but also remember that the dementia can be a symptom of depression. So we have to be careful to discriminate. And there is a so-called Beer's list, which is the medications that are suggested to be avoided in the elderly. Please go to the website and check it out. And here we have a quiz, but first of all, let me say something about the quiz because we have gotten some feedback about it. First of all, we don't know who responds, who says what. This is a totally anonymous thing. It has nothing to do with the exam. It's not being recorded anywhere. It is basically just you can test your knowledge, and you can practice for the exam because these are the kind of questions that you're going to see there. Okay, so this is a 50-year-old man, presents to your office with depression, irritable fidgets, rub his lower back, he's on methadone, and yet barely sleep at a few hours, feeling hopeless, and vague suicidal ideation. The following should be your antidepressant long-term treatment plan of choice. So imagine that not the moment you start the medication, but think long ahead. I'm going to put this patient on this medication and intend to keep this patient on this medication for several months, which would be the medication?
People, you getting this one? Oh.
Let's try to reach 80%. No more? Okay, so let's look at the questions. So like I said, patients with chronic pain disorder and depression typically need high dosages of antidepressant. You will not succeed with low dose of any antidepressant. So that rules out a typical dose of duloxetine and a low dose of nortriptyline. Bupropion has no effect on pain. So again, you think about a medication that is going to treat both the depression and pain. Citalopram is not going to affect pain. So we have 3 potential medications that can affect pain because they are SNRIs, so nortriptyline and the duloxetine. So these are the 3 choices. Again, low dose nortriptyline is not going to be useful because it's low dose. So we have high dose duloxetine versus typical dose duloxetine. And it's going to be the high dose duloxetine because that's the one that is most likely to affect the depression, because it perhaps also has some additional pain effects, so you can reduce both, and that's how you will have the highest likelihood of treating your depression. Okay, so is it clear?
Private joke.
Okay, so this is again something that tells you how to think about these cases, because these are the situations that you're going to face in real life. So there are situations that you don't make decision on a single thought. You're making decision on several thoughts. So there's a couple of little blocks that you put together in order to get the response. So there is depression, there is the pain, and then you have medication, the high dose medication and low dose medication, or SNRIs and medication are not SNRIs. So you put all this information together like a little matrix, and you pick the one that is going to be where the treatments and the condition meet. And the treatment and condition, it meets at the point of a high dose SNRI. Okay. So this is the end of this one, and without interruption, we're going to go to the last set of slides, which is only 18 slides. But I have to get out of this and come back in just a few seconds.
Doctor, if it's okay, I'm gonna run the attendance poll.
All right, so let's go to the last section here, monitoring, switching, discontinuation. So this is how you behave once the patient is, I'm sorry, it just keeps popping in the middle of the screen. This is how you behave and what you do in a situation when you have a patient in ongoing treatment. So let's talk about testing. You can test for certain things, and sometimes it is important to test before you start treatment. And there is very little, but not zero, hard set rules. You have to use clinical judgment. So for instance, you plan to start the patient, a young 22-year-old person on, well, let's make it even less problematic, a 28-year-old person on escitalopram versus an older patient with alcoholic and duloxetine. You will not have to do any kind of testing, laboratory testing, or any other kind of testing with the young guy on escitalopram, but you will probably want to do something on the old alcoholic on duloxetine, and what it is, we'll discuss a little bit later. When I say use clinical judgment, don't forget medical legal considerations. I mean, of course, the first point is treating the patient, and the second point and the 6 points and everything else, but you should not forget about yourself. So certain things you will do to make sure that people who look into what you do, they can tell that, yes, you did what was supposed to be done. So what can you test? These are things that you can test before and then during the treatment. So one of the things that you can test, and you don't have to be a prescriber to do that, is the different kind of laboratory, the different kind of numerical scores of depression, anxiety, quality of living, etc. So you may want to have a baseline BDI score, etc. You can test laboratory values, you can test for vital signs, you can get an EKG, and you can get the baseline genetic profile. So why would you want to have baseline numerical testing for depression? Because it gives you a sense of objectivity, but probably that you guys know it better than I am. But anyway, so it's in the slides. It gives a sense of objectivity in assessing the severity. You can get information on symptoms that you might have missed during the interview. And patients may over or underreport severity. So we have to make sure that you compare it with your clinical impression and then BDI, PHQ-9, etc. What can you test in the laboratory, and why? So before you start any kind of antidopaminergics, such as even Latuda, which is not that likely to cause problems, you want to get baseline BMI, weight, waist circumference, fasting lipid profile, fasting serum glucose, and hemoglobin A1C. I would highly suggest you do this baseline testing. It is very important because most of these medications can have later problematic complications in that, and then you need to have something to compare it with. Well, I would presume that if you have prescriptive authority, you would have authority to order a lab test or blood test. I would be very surprised if you did not, but again, I have no idea. So you will have to find it out. Actually, frankly, you can order this blood test. You can order this blood test for yourself. There are internet sites that you can order labs for yourself. You don't even need the doctor's order. So you can probably order these tests for patients.
Not order them, but tell them to order them themselves because the doctor signs on it.
Yeah. If you're going to prescribe medication that increase blood pressure or decrease blood pressure, then you may want to get a baseline level for that. not that important, but so not as important as the metabolic baseline. For lithium, it is obligatory to get baseline complete blood count, basic metabolic profile, electrolytes, BUN, creatinine, and the thyroid-stimulating hormone, TSH. You have to get these before you prescribe lithium. Now, sometimes you prescribe lithium on the fly, patient comes in suicidal, you're not going to wait for the blood test, but you prescribe lithium and give the blood slip to the patient, go to the lab the same day or the next day. It's not going to be affected by lithium much. It is still going to be considered baseline. Okay? With potentially hepatotoxic medications like duloxetine, mifepristone, MUIs, especially in patients who have the risk of perhaps already having some liver problems like alcoholics, then you do a baseline liver function test. With the potentially cardiotoxic medications like quetiapine, citalopram, TCAs, high-dose quetiapine, you get a EKG and make sure that you also get a QTc interval, because it is not part of the just like a regular EKG, at least not necessarily. Now, if you see a patient who comes in for the first time with a history of multiple treatment failures, then you can test for TSH level, which if it's high, it would indicate low thyroid function. Why? Because low thyroid function would induce the brain to produce more TSH to sort of guard the thyroid gland to create more thyroid hormones. So high TSH is a sign of low thyroid function. Low TSH is the sign of high thyroid function normally. These vitamins, vitamin B12 and D3, they can be low and they can contribute to depression. So in a long history of treatment-resistant depression, you check vitamin B12 and D levels. You may want to check homocysteine levels, which can be a sign of, in case you get problems with the folate mechanism, metabolism. You may want to check for hepatitis C, HIV, RPR, which is a syphilis test. You do this if they make clinical sense from the history that you have gathered. And finally, you can get a brain MRI, again, if it's going to make sense. So there's a suspicion that the patient may have had a recent head injury or may have perhaps brain tumor, and depression is one of the symptoms, then you may want to order or get ordered a brain MRI. And if you have patients with comorbid substance abuse, you get these toxicology tests. You can do baseline psychogenetic testing. You can consider the case of a history of repeated treatment failures or a history of unusual reactions. It allows for more rational selection of meds, less guessing. And these are the different kind of factors that are tested, and basically it's just a repetition of something I said earlier, and you can look at the sample report among the uploads. Ongoing monitoring of parameters. Just give me 1 second. I need to do something. Okay. What do you ongoing? So if you haven't done them before, then you can do all this later. Some of them are mandatory, like the lithium. If you give someone lithium, especially, I mean, if you don't have to do it, if you give someone only 3 or 6, maybe 600 milligrams, but anything over that, you have to have the following things monitored with lithium: level, the TSH and electrolytes that can be affected by the lithium. Also, you can monitor the level of TCAs, tricyclics. We do these from weekly up to 6 to 2 months. So let's say you have a lithium patient, you put in a lithium, you get a level in week 1, then you get a level in week 2, so 2 weeks later, then you get a level in 4 weeks, and after that you get levels every 6 to 12 months. There are some recommended medications, but these are not necessary. The EKG ongoing monitoring is yearly with involved medications, or maybe 6 months if it's like teetering or on the borderline. And the metabolic ongoing monitoring, anti-dopaminergics, I get a lipid profile, waist, BMI, etc. With the duloxetine, etc., get liver function tests, and with the lithium, you get the TSH and the electrolytes. So these are ongoing. And again, if you haven't done them before, any of the baseline tests can be done when it seems clinically reasonable. You also monitor the effect of the treatment. So is it really working? So one of the things that you monitor is the patient actually feeling better. And it's a very important, I would say, no, not very important, a very useful question to ask. So patient says, oh yeah, I feel better. Then you ask, so what's better and how is it better? Like anything, don't just take an answer for granted. No, granted, don't take it literally, and always try to find out a little bit more. You ask, you find out if the symptoms are diminishing, which symptoms are diminishing, which symptoms are not diminishing. How is the suicidal ideation? One of the most important things to follow up. How is insomnia? Is the motivation better? What about the side effects? How about the sexual side effects? Are they getting better? How is the dry mouth? Is it getting better? Is the quality of life improving? How? Is the psychosocial functioning improving? So what happened? What's better? Did you go back to work? Are you reconciled with your spouse, etc.? Again, are there any side effects? And think yourself, have I actually asked about the side effects? There are side effects that patients tend to complain about, like sleep. And there are side effects that patients don't like to complain about, like sexual side effects. So make sure that you follow up on those then. If it's not working, then you have to rethink your entire strategy. You may have the wrong diagnosis, you may have the wrong medication, you may have a wrong choice of medication, you have the wrong dose, patient never takes the medication, there are the medical reasons that are interfering, metabolic hyperactivity may be occurring, or the medication, the condition is treatment resistant. If it used to work but it's no longer working, then this is the first assumption. Patient is not taking the medication as prescribed. Always ask about it. Then you have a tachyphylaxis that can occur, tardive dysphoria, which is a possibility, or sometimes something interferes with the absorption. Something interferes with the metabolism. Somebody started a new medication, went on a great food diet. The baseline severity of the illness may increase and break through the certain level of protection provided by the medication. For instance, the winter occurs in seasonal affective disorder. New stressors occur, new comorbidities can occur. So you need to ask for them and look for them. So here's a quick quiz. We have a 40-year-old obese patient stable on this medication, undergoes bariatric surgery. She was off antidepressants only for 1 day. During the surgery, 1 week after, she comes back presenting depressed, even more so after 4 weeks. What would you do? So in order to answer the questions, you might think about, so what happened? What is being prescribed? What is it described here? What happened to the patient? And then you can answer what would you do?
I may not know what that means. The IR. What is IR preparation?
So if anybody doesn't know, IR is immediate release. ER is extended release.
Random answer.
Yeah. All right, so I think I have enough answers to see that probably I should tell you what's going on. Actually, it's a clinical case from my own case history. So the answer is actually E. You change the venlafaxine ER to the same total amount to the immediate, so the immediate release 75 milligram 3 times a day. It's the same total daily dose, but what happens? So she got bariatric surgery. As a result of that, the passage time of the medication in the bowels reduced considerably. There was no time for enough venlafaxine to get absorbed from the bowels on the extended release. So all you had to do is to change it to the immediate release, which she was taking 3 times a day, and she got the same amount of antidepressant effect back. Okay, so it is depending on the clinical situation why you want to pick one versus another. All of them would be could be useful in different clinical situations. In this particular clinical situation, that's the reason why the antidepressant effect went away.
There's a question.
Why don't you do IR augmentation and decrease ER rather than switching glucose? But it's just simply easier to get one medication prescribed instead of 2 medications. The ER is not going to be not going to be working. It's not going to be staying in the system long enough to be reliable. So you don't want take an unreliable medication and then add something else to it.
Hi, sorry. I thought it was easier to just speak. Can you hear me?
Yes.
My question was, rather than completely switching from the extended to the immediate release, can you just augment with the immediate release and decrease the extended release, but still keep some of the extended release, because that gives them a little bit of a solidity?
Well, yes, that you can do that, but that was not one of the questions. So again,
then I misunderstood. I'm sorry.
Yeah.
Okay, thank you.
How long to continue? Again, as Dr. Myers said, treat to remission. There's almost never a medical reason to stop an antidepressant, so we should continue as long as it may clinically necessary. Rather err on too long than on too short. It's the first episode, continue about 6 months. If it's peripartum, for 1 year. Second episode with risk factors lifelong, without risk factors at least 2 months while in remission. And the third episode, lifelong. But clinically, usually people accept only lifelong treatment after 4 or 5 severe episodes. How to discontinue antidepressants? Gradual tapering is recommended for all antidepressants almost always. Reduce it by about 25-33% at high dosages, and you can go to 50% at low dosages. So for instance, this would be a taper schedule, 200 to 150 to 175, 50, 25, 0 milligrams. Let's say every 2 weeks, every 3 weeks, up to every 8 weeks, depending on prior history and the patient's preference. The more severe the prior history, the slower the process. And again, do it rather too slow than too fast. Some patients may require very, very fine steps at the end, so 25, 15, 10, 5, etc. And most SSRIs, believe me, are not come in a liquid form, so you can give very fine dose ranges, tapers with medication. The most difficult medication to taper off is paroxetine and venlafaxine. Fluoxetine and vortioxetine seem to be the easiest to taper off, and because of venlafaxine is because of, these are because of the half-life. These are the shortest half-lives, these are the longest half-lives. Antidepressant discontinuation syndrome, it is not very frequent, but it occurs in 5 to 10% of people. It can, the onset depends on the half-life of the drugs. Usually it gets resolved in 1 to 4 weeks, but sometimes there are current reports lasting incredibly long times. Again, slow tapering seem to have some effect, but not if somebody is going to get it, is going to get it whether you do it slowly or fast. You can minimize that by switching from paroxetine or venlafaxine to fluoxetine and then tapering off from that medication, because it's less likely to cause discontinuation syndrome. There's no reliable treatment, but it's usually self-limiting. It's typically mild, but it can be very disabling. And again, it's one of the things that you make sure to prepare the patient to the potential of this condition, even before you give the medication, but definitely when you embark on discontinuing. You can tell the patient that you can expect these symptoms to occur. And this is just a mnemonic for people who like these kind of things, all these different kind of symptoms that can occur. The most frequent ones are headaches, muscle aches, headaches, vivid dreaming, lightheadedness, and brain zaps. When to stop suddenly? When there's a full-blown manic switch. Sometimes you just reduce it if in case of mild hypomania. In case you can just reduce it by 50% and see if the hypomania gets reduced. But if there's a full-blown manic switch, you just stop right away. You can also suddenly stop if there is serotonin syndrome, and also stop suddenly if there is suicidal ideation caused by the antidepressant. Okay, so these are the 3 conditions in which you can suddenly, or you should suddenly stop an antidepressant. Patients self-discontinue antidepressant, a large number of cases. I think Dr. Myers mentioned that up to 30% of patients just don't even pick up their medications. So just think about that. So patients discontinue when the side effects seem to outweigh the therapeutic effects. Sometimes it's objective, sometimes it is subjective. Sedation, loss of libido are the most likely reasons. Weight gain is usually occurs so late and so they don't usually tie it to an antidepressant because it's so insidiously appearing. And anxious fear, somatization, misinformation coming from family or other forces can also make people discontinue antidepressants.
There's a question.
Can you repeat your statement about brain zaps, please? So brain zaps is one of the symptoms of antidepressant discontinuation. It is an electric feeling inside the patient's brain. They feel that it's just as if somebody zapped them with some electronic device or something. And brain zap sounds like something from, yes, but that's actually the official terminology, which comes from patient groups where patients describe these symptoms among themselves. One of the most disturbing situations of situation when patients discontinue medications is when they feel better. You should warn patients not to stop exactly when they started to feel better. Patients tend to discontinue medications in usually between week 8 and 12, because that's when the antidepressants finally working, they are better, and then they just stop. And that's when the rebound depression occurs. Depression comes back in its form, and not just what it's used to be, but even worse, because basically you just feel sudden antidepressant withdrawal. So you get the opposite of what you were treating before. So you have to warn patient every time you put them on antidepressant, please do not stop taking it when you feel better. That's exactly when you need to continue, and that's exactly why you need to continue, because you feel better. And if you stop taking it, you will feel worse than ever. You need to tell this to your patients. And this is the final slide. How to change from one antidepressant for another. The rule of thumb is cross taper. So this is an example. I probably don't need to read it. You just study it for yourself, how to switch from a high dose antidepressant to another high dose antidepressant, which is more involved, and how to switch from a low dose antidepressant to another low dose antidepressant, which is easier. What I have is I have this as a Word document template, and I just print it out and I just write these things into the patients and give it to them. And finally, let's have one quiz because just because of the 3 minutes, and then we are over. So 55-year-old woman present with depressed mood, decreased energy, weight gain, and normal appetite. It is summertime, but she wears a thick sweater. Besides depressed mood, she complains about becoming very forgetful. She never had these symptoms before, denies any past psychiatric history. She looks depressed, tired, slowed speech and cognition, otherwise under her mind. Which test would most likely lead to the correct diagnosis? Okay, so with 50% of votes, we have most of you guys got it right, so it's encouraging that the rest of you guys also would have gotten it right. So yes, TSH would most likely to the correct diagnosis of hypothyroidism. We're gonna skip this quiz here. One of the things that you would notice that she wears a thick sweater, which is, it brings up the suspicion of hypothyroidism, and that you order a TSH test to confirm it or disconfirm it. Okay, I see there is one more question here. Okay, that's not a question. Okay, so before we stop, we have one more minute. Any questions?
Just tell them that they can email us.
Okay, so then that's it. Feel free to email any questions, comments that you have. We are happy to answer any questions regarding the presentation or any kind of slides. And if you want to answer the last question yourself and send the question to us and your answer to us, please do so. Okay, and thank you for listening to us, and good luck to all of you.